Metabolic dysfunction-associated steatotic liver disease, formerly known as non-alcoholic fatty liver disease, is now one of the most common chronic liver conditions worldwide, affecting a substantial proportion of adults. To understand whether dietary supplements can help, we must look at how fat accumulates inside hepatocytes. Under chronic conditions of caloric surplus, physical inactivity, and hepatic insulin resistance, the liver undergoes accelerated de novo lipogenesis, converting excess dietary glucose and fructose into triglycerides. When fatty acid influx and synthesis outpace mitochondrial beta oxidation and very low-density lipoprotein export, lipid droplets accumulate, creating steatosis. Over time, excessive saturated fatty acids trigger mitochondrial dysfunction, oxidative stress, and endoplasmic reticulum stress, a state known as lipotoxicity. This can trigger inflammatory cascades, recruiting macrophages and activating hepatic stellate cells that deposit collagen fibers, leading to steatohepatitis and fibrosis. While the internet frequently promotes supplements as rapid cures, clinical hepatologists emphasize that no dietary supplement has been proven to reliably reverse hepatic steatosis on its own without addressing the underlying metabolic drivers. Among single micronutrients, vitamin E, specifically natural alpha-tocopherol, possesses the strongest histological evidence from randomized controlled trials. In the landmark PIVENS trial published in the New England Journal of Medicine, non-diabetic adults with biopsy-proven steatohepatitis received 800 international units of natural vitamin E daily for 96 weeks. The researchers absorbed modest but statistically significant histological improvements, including reductions in steatosis and lobular inflammation compared to placebo. As a potent lipid-soluble antioxidant, alpha-tocopherol helps neutralize lipid peroxyl radicals within hepatocyte membranes, dampening oxidative stress. However, hepatology guidelines highlight critical nuances. Vitamin E did not show consistent efficacy in reversing hepatic fibrosis, and its benefits are not clearly established in patients with concurrent type 2 diabetes. Furthermore, long-term high-dose vitamin E supplementation carries potential safety considerations identified in large trials, such as hemorrhagic stroke risks and prostate health concerns in men, meaning it should only be used under direct physician supervision. Omega-3 polyunsaturated fatty acids, particularly eicosapentaenoic acid, or EPA, and docosahexaenoic acid, or DHA, are widely studied for metabolic liver health. At a molecular level, omega-3s act as natural signaling ligands that activate peroxisome proliferator activated receptor, or PPAR-alpha, while downregulating sterol regulatory element binding protein 1C. This dual action stimulates mitochondrial fatty acid beta oxidation and dampens hepatic de novo lipogenesis. Clinical trials suggest that omega-3s can modestly reduce hepatic fat and triglyceride levels, although their effects on steatohepatitis and fibrosis remain uncertain. Systematic reviews of clinical trials using MRI-PDFF generally support modest reductions in liver fat percentage. Consequently, clinical guidelines recommend omega-3s as a supportive adjunct for hypertriglyceridemia in steatotic liver disease, rather than a primary disease-modifying cure. Beyond vitamins and fatty acids, several botanical compounds have garnered public interest. Milk thistle extract, standardized for the flavonoligin complex known as silymarin, has been investigated for its antioxidant, anti-inflammatory, and anti-fibrotic properties in preclinical models. Some human trials report modest reductions in serum alanine aminotransferase and aspartate aminotransferase levels, markers of hepatocyte stress. However, clinical reviews note that formulation bioavailability varies widely, and large-scale biopsy-confirmed human trials proving histological disease reversal are limited. Similarly, compounds like berberine, coenzyme Q10, and phosphatidylcholine have demonstrated modest improvements in insulin sensitivity and metabolic markers in early trials, but remain investigational. Crucially, hepatologists issue a strong caution regarding unregulated liver detox blends. Contaminated or poorly formulated herbal supplements are a recognized cause of herb-induced liver injury. Any supplement must be verified for third-party purity and discussed with a physician to avoid placing additional metabolic burden on the liver. When evaluating the scientific hierarchy for managing steatotic liver disease, lifestyle interventions remain the definitive cornerstone.
Clinical guidelines from the American Association for the Study of Liver Diseases and the European Association for the Study of the Liver establish that weight loss of at least 5% can reduce liver fat, while greater sustained weight loss, particularly around 7 to 10% or more, is associated with greater improvements in steatohepatitis and may improve fibrosis. Adopting a Mediterranean dietary pattern rich in extra virgin olive oil, vegetables, legumes, nuts, and whole grains, while strictly minimizing sugar-sweetened beverages, high fructose corn syrup, ultra-processed foods, and alcohol, creates the sustained caloric and metabolic deficit needed for hepatocytes to clear stored lipids. Combining this with regular aerobic and resistance exercise enhances peripheral insulin sensitivity. While supplements like high-purity omega-3s or supervised vitamin E may serve as supportive adjuncts for select individuals, true liver recovery is driven by sustained, comprehensive metabolic health. Medical disclaimer: this video is for educational and informational purposes only. It does not constitute medical advice, diagnosis, or personalized treatment for liver disease. Always consult a qualified hepatologist, gastroenterologist, or healthcare professional before taking high-dose supplements or changing your medical regimen.